Happy Gauri Ganesha to one and all. A warm greetings from JSS Academy of Higher Education and Lessons. Early childhood caries is the presence of one or more decayed, cavitated or non-cavitated, missing due to caries and filled surfaces in any primary teeth of the child under age 6. The prevalence of early childhood caries is spread across globally. The prevalence ranges from less than 25% to more than 75%. A recent systematic review on global prevalence of early childhood caries stated that the polled prevalence is about 48%. A systematic review of early childhood caries in India showed that the overall prevalence of ECC in India is around 49.6%. When we check with each state had a prevalence of more than 40%, which showed that the high prevalence of ECC in India. So any disease which has a prevalence of more than 40% needs to be considered seriously. So to combat any disease, the preventive measures need to be taken. So these preventive measures can be at 3 stages. That is primary prevention, secondary prevention, and tertiary prevention. Today, the focus of my presentation is on primary prevention of early childhood caries through infant oral health care. So, who is an infant and what is an infant oral health care? Basically, infant is a child from birth to 12 months of age. According to the AAPD, it recognized infant oral health care as the foundation upon which the preventive education and the dental care must be built to enhance the opportunity for the child to have a lifetime free from preventable oral diseases. When we look back to the history, the not much importance was given to the infant oral health care, neither to the first dental visit. It was in early 1967 that AAPD began promoting that the oral health as a part of the child's general health. It was in 1986 that American Academy of Pediatric Dentistry first adopted or approved the policy on infant oral health care. In 1995, the concept of anticipatory guidance was described, and in 2001, the Canadian Dental Association endorsed the first dental visit to be at age 1. In 2002, the dental home concept was established, and in 2003, the American Academy of Pediatrics shifted the first dental visit from 36 months to 1 year. In 2006, the New York State introduced the perinatal and infant oral health guidelines. In 2007, the ADA also adopted the dental home should be established by age 1. In 2009, the perinatal oral health care guidelines was introduced. And in 2011, the AAPD celebrated 25th anniversary of AAPD's infant oral health policy statement. Now, this policy or the guideline is 36-year-old. The American Academy of Pediatric Dentistry, IAPD, AAP, AAPHD, as well as ADA, all these policymakers adopt that the children should be seen by the dentist not later than 6 months after the eruption of the first tooth or by 1 year of age. Although this protocol has been, as I said, been adopted since 36 years, the dental professionals have not wholeheartedly endorsed this recommendation, and many parents and caregivers, even to date, are not aware about this advice. The AAPD's recommendations on infant oral health care goes like this. They have given 7 recommendations. The first being advise the expecting or the new parents regarding the importance of their own oral health. Encourage them to establish the dental home, wherein in dental home, the medical examination, dental examination, risk assessment, and anticipatory guidance for the infants is given. The third recommendation is caries preventive information regarding the high sugar consumption, brushing twice daily, and safety and efficacy of fluoridated community water is given. The fourth recommendation is assess the caries risk to facilitate the appropriate preventive strategies. Provide the information to the parents regarding the common oral conditions in the newborns and the infants, non-nutritive oral habits, teething, growth and development, and orofacial trauma. If there is ankylosing, surgical intervention should be assessed on the individual basis. And if there is a presence of natal or the neonatal teeth, that needs to be addressed and educated to the parents. The IAPD recommendations also gives the recommendation on the same line, like limiting the sugar intake, avoiding the nighttime bottle feeding, then no bottle or breastfeeding after 12 months of age, brushing twice daily with 1000 ppm of fluoridated toothpaste with age appropriate amount of paste, and dental visit for comprehensive care at first year of life. Now let us see. So these were the recommendations from the policymakers. Let us see what is the perspective of caretakers of the child towards infant oral health care. A study was done to know the knowledge, attitude, and practice of mothers towards infant oral health care, and the results showed that 86% of the mothers were unaware about the first dental visit. Also, they were unaware about when to start using the toothbrush. Like 72% of the mothers started using the toothbrush and toothpaste only after all the primary teeth erupted. That is only after 3 years. Next, going to the perspective of the dental student, what is the impact of infant oral health program on dental students? The authors concluded that the graduates were least likely to form a caries risk assessment after the to do the caries risk assessment, and the findings from this study highlighted that there is a need for the earlier and greater exposure to the infant oral health policies and importance of promoting the awareness about the risk assessment and oral disease management. This was from the dental students' perspective. Coming to the graduating medical student perspective, when the question was asked whether the counseling is required to prevent the early childhood caries, 92% of the medical students said that it is not required. And 62% of the medical students were unaware about the first dental visit. Now let us move on. What is the perspective from the pediatrician's point of view? Most of the pediatricians were aware about the policy guidelines and the recommendations, but majority of the pediatricians were not referring the parents to the dentist for the first dental visit at age 1. They were referring only if they had noticed caries in the oral cavity. And also, the many pediatricians felt that the knowledge that they imparted on infant oral health care during their medical school was really inadequate. So when we were conducting this study, we came across this beautiful article by Arthur Novak, who is actually the father of infant oral health care. This article was published to celebrate the 25 years of implementation of infant oral health care policy. This article changed my vision of looking the pediatric dentistry. So after going through this article, we thought, and why don't we establish the infant oral health care in our setup? Because most of the dental schools typically provide care through the number of venues like hospitals, clinics, dental schools, as well as the mobile vans and community-based centers. So the infant oral, though we can establish the infant oral health care in these centers, although we can establish, but still the establishing an infant oral health program in the pediatric section will be more easily accessible, because the mother visits the pediatrician more than 20 times in the first 2 years of life. So it is more easily accessible, and also it is an effective way to prevent ECC. Because whenever we give the guidance through the pediatrician, it is more effective. Hence, with this, we established the baby oral health promotion clinic in the JSS hospital. JSS hospital in Mysore is a multi-speciality hospital with 1,800 beds. It is in the city center, which caters to the needs of both rural and urban population. Around 600 babies are born per year in this hospital, and more than 47,000 children visit the pediatric OPD every year, and among them, more than 15,000 are below 1 year of age. And coming to in the vaccination unit of the pediatric department, more than 10,000 children are vaccinated per year. So this was easily accessible for us to implement the infant oral health care. Hence, in 2014, we established Baby Oral Health Promotion Clinic. This was inaugurated by Stephanie Russell from New York University. The rationale of establishing this clinic was to provide the preventive and interceptive oral health care for infants and young children. implement oral hygiene measure right from the infancy, and guide them about the appropriate oral hygiene, assess the risk factors for early childhood caries, dietary assessment and modification, provide age appropriate guidance for orofacial injury prevention, and referral to JSS Dental College and Hospital for those patients who are at high risk. So in this clinic, we give anticipatory guidance under the following headings. Oral health risk assessment is done using this proforma. This is basic. Mainly, we are following the camera caries risk assessment because this was more in detail for the risk assessment. And once the risk is assessed, the low risk patients are followed up every 6 months, and high risk patients are followed up every 3 months time. Then we help in establishing the dental home. As we all know, the dental home is an ongoing relationship between the dentist and the patient, inclusive of all the aspects of oral care delivered in a comprehensive, continuously accessible, coordinated, and family-centered way. The dental home should be established not later than 12 months of age to help the children and their families institute a good oral health. In this dental home, we can address anticipatory guidance and give preventive, acute and comprehensive oral care, and refer to the dental specialist whenever appropriate. Regarding the teething, a study was done on the mothers to know where they actually seek the advice whenever there is a teething problem. To our surprise, 0% of the mothers seek the advice of the dentist, and only 5% of the mothers seek the advice from the pediatrician. Regarding the oral hygiene practice, as I mentioned prior, the mothers were not introducing the oral hygiene measures up to till 3 years of the child's age. One of the reason was like the child would not split the paste whatever they used, so they used to never introduce the toothbrush and paste up to 3 years. And second thing was they were unaware when to introduce the oral hygiene aid. So we here give individual guidance based on the child's oral dentition. We have an individual models like this where we show where the tooth eruption based on the age appropriate tooth eruption is also there. So we give guidance individually to each mother on using the proper oral hygiene aids. Along with that, we give the specialized chart to the mothers where the mothers can note down the timing of eruption of each teeth. We also give guidance on the injury prevention of primary teeth. Along with that, once the counseling, one-on-one counseling is over, we give a pamphlet where all the information right from the prenatal to the natal, also the development of the caries, what are the factors, what are the healthy food that can be given to the child to prevent the early childhood caries, what are the oral hygiene practices, all these are reinforced in this pamphlet. To know the success of this baby oral health clinic, we took 150 birth cohort and followed them up for 5 years. The caries risk assessment was evaluated using the caries risk assessment form, which I showed earlier. After 1 year, we found that 37% showed the risk of developing the caries. Those children who are showing the risk of development of caries, we followed them every 3 months, and all the oral hygiene instructions and the education were reinforced every 3 months. So this was followed up for 5 years, and at the end of 5 years, we could note down that only 2% of the child, 2% developed the caries, and 98% remained caries free, showing that the establishment of this clinic and constant support and constant education to the mothers actually helped in preventing the occurrence of early childhood caries. These are the various projects which has been done in this clinic. And these are the few publications. Recently, we got recognized from the International Academy of Pediatric Dentistry, and we were awarded with a Colgate Bright Smile, Bright Future Award on 28th Congress of IAPD. So establishing this clinic was a win-win situation for both the patient as well as for the clinician or the researcher. From the patient perspective, we educated the mother about the oral hygiene measure, which in turn benefited the child with zero cavities, which helped in the optimal growth of orofacial skeleton. It improved their general growth and development and reduced the financial burden on the parents, which in turn created a healthy society. a research perspective, establishing this clinic created a good cohort to study. Either you can through the cross-sectional observational or even the randomized control trials can be done, which in turn gives us the publication in good impact journals. So, friends, we, the pediatric dentistry, let us join hands together to create a zero cavities in these innocent um, um, children and preserve these innocent smiles. Because, as Pinkham said, the child in the first year of life is the most desirable preventive patient, in that whatever is done preventively for this patient will have a lifetime effect. This article changed my perspective of seeing the pediatric dentistry. Establishing of infant oral health care, which was a dream, actually, it can be a reality if we all join hands together with healthcare professionals as well as the caretakers. With this, I would like to end my presentation with acknowledgement to my university, JSS Academy of Higher Education and Research, for providing me with all the facilities for establishing my this clinic. My in-depth thanks to Dr. Nandlal sir for his constant support and encouragement. I would like to thank the SICRI team. A special thanks to Dr. Muthu sir for giving me a platform to talk in this SICRI conference. Thank you, one and all.